Welcome to the workshop, Ask the Transplant Experts. Before we begin, I'd like to thank Pharmacyclics, an AbbVie company, and Janssen Biotech, as well as Takeda Pharmaceutical Company, whose support helped make this workshop possible. My name is Sue Stewart, and I will be your moderator today. It's my great pleasure to introduce to you today the panel of transplant experts, Dr. Richard Champlin, Dr. Luke Mountjoy, and Dr. Luis Pineiro. Dr. Champlin is Professor of Medicine and the Chair of the Department of Stem Cell Transplantation and Cellular Therapy at the University of Texas MD Anderson Cancer Center in Houston. He's worked in the field of stem cell transplantation for more than 40 years and is a pioneer and leader in the use of stem cell transplantation for the treatment of blood cancers and bone marrow failure diseases. Dr. Mountjoy is an assistant member physician at the Colorado Blood Cancer Institute and part of their lymphoid disease group. And Dr. Luis Pineiro is the director of the Baylor Scott White Texas Oncology Blood and Marrow Transplant Program in Dallas, Texas. He's been in practice for more than 30 years, treating patients with a stem cell transplant and other cellular therapies. The first question is from someone who wants to know about Evusheld. They said, I am 6 months post-BMT and have had Evusheld shots. When should I start revaccination for COVID? Dr. Champlin, do you want to handle that?
Sure. So early after the transplant, the immune system is still recovering and won't respond optimally to vaccines. And so even though we've given patients the COVID vaccine, we're not confident that they're going to have an effective immune response. So the Evusheld is a recent product, which is a monoclonal antibody. It's two different monoclonal antibodies against the COVID virus itself. And so it provides passive immunity, and it lasts for several months. And I actually asked the same question: is when after the Evusheld should one get the COVID vaccine? In my own mind, it makes sense, to wait a few months for the antibody levels to go down, so they won't bind the vaccine. But apparently, the company doesn't have a specific recommendation in terms of how soon to do the vaccine. So I'm not sure if any of the other speakers have more insight than I do, but we do recommend the Evusheld for our patients early post-transplant, and then beyond 1 year, we recommend that they get vaccinated, and we recommend that even the early patients get vaccinated several months after the Evusheld.
All right, thank you.
Yeah, just to piggyback off of that, we actually asked the Evusheld company that too, and because we didn't have a good answer either. And what we've been doing is at least 2 weeks, if not longer, but at least 2 weeks on either side of the Evusheld, whether before or after. The other thing to keep in mind with that Evusheld is that it originally was 150 milligram dosing, but with this new Omicron variant, the BA2 variant, they've recommended a 300 milligram dose, which provides better protection. So if you originally got the 150 milligrams, you'd be eligible for a supplemental dose to help optimize your titers.
Good to know. Thank you. Dr. Pineiro, I'll ask this question to you. What additional vaccination should a transplant patient receive after completing a stem cell transplant? This person has had the flu, COVID, pneumonia, and the typical newborn vaccine, and has also had titers for MMR. Is there anything else that she should be doing?
No, that's just about cover all the recommended vaccines. The only thing that we are incorporating in these vaccines is the inactivated or shingrix vaccine. That's to prevent herpes zoster. Most of the time, while we're taking immunosuppressants, we keep the patients on oral medications to prevent shingles or herpes zoster. But it would be desirable at some point to get the shingrix vaccine. That is, again, an inactivated vaccine. There is a live vaccine against shingles, but we do not recommend that so far.
All right, thank you.
Yeah,
Here's a question.
One
Go ahead.
comment that is, there was a study in autologous stem cell transplant patients showing the benefit of that. It hasn't really been formally studied in allogeneic transplants, and so no one is quite sure the efficacy in the allo transplant setting. But we do recommend it, but we recommend it 2 years after the transplant to allow the immune system to more completely recover before doing it.
Great.
And they have to, of course, be off immunosuppressive treatment and not have graft versus host disease.
All right. Okay, Dr. Mountjoy, perhaps you can handle this one. I've been told by some rheumatologists that I have rheumatoid arthritis and Sjogren's, I believe is how you pronounce it. But then others say I just have rheumatoid arthritis titers and no signs of Sjogren's. I'm extremely confused about my autoimmune system, and again, cannot find a good rheumatologist. What can I do? Sjogren's has a lot of symptoms similar to GVH symptoms.
Yeah, it's a little bit of a complex question. I don't mean to speak for the three of us, but really important to have a good rheumatologist to kind of advise you on that question. To your point, it's hard to kind of tack down some of these autoimmune disorders. There's kind of blanket statements that they have about diseases where there's overlap between rheumatoid arthritis and Sjogren, what they call them mixed connective tissue disorders. And those are really a clinical diagnosis, if you're struggling with dry mouth, dry eyes, things of that nature. It's not all on the antibody titers. It's a clinical diagnosis as well. So I do think it's important to probably worth getting a second opinion from a rheumatologist and seeing if they think you have an overlap syndrome or if you have one thing or the other. But it's important to tack that down because you wouldn't want to get on kind of willy-nilly treatment until they know exactly what they're treating. But very difficult and not an uncommon predicament to be in with these autoimmune connective tissue diseases.
All right, anyone else care to comment? All right, well, you talked about dry eyes and GVHD in the eyes, so this is a question that relates to that. This gentleman wants to know what your thoughts are on using Jakofy for GVHD of the eyes. He said one doctor wants to keep him on this dose and another wants to wean him completely off systemic therapy.
Yeah, it's an interesting question. So Jakofy was approved for chronic GVHD based on the REACH3 trial, where they had good response rates with that. It was a randomized trial. Jakofy is pretty well tolerated medicine. So about a 50% chance of having a response from that. Now, it's possible that one of your doctors is saying, hey, let's get you off of systemic treatment and plan for just eye drops or some topical treatment for your chronic GVHD of the eye if it doesn't, if you don't have systemic symptoms elsewhere. That is a reasonable thing to do. If really the only place you're struggling with chronic GVHD is in the eye, it's reasonable to trial just topical local eye drops and get you off of systemic stuff. But if you're having systemic GVHD symptoms, I would be leery to back off the Jakofy.
All right.
And I would add to that.
Go ahead.
Sometimes, the Jakofy is going to work if there is active inflammation or active GVHD. Many times, I use the term burnout GVHD, meaning that the tear glands are kind of burned. They're non-existent now. So we persist with dry eyes, and not necessarily to keep you on immunosuppressants is going to make a big difference.
All right.
Yeah, eye symptoms are often occur sort of in isolation or disproportionate to the rest of graft versus host disease, and so seeing an ophthalmologist that's well versed in this area is important. And often they have some special pros contact lenses that can be used to help people with GVHD of the eyes.
All right. Dr. Champlin, maybe I'll start with you on this one. This is from a woman who says, I have GVHD of the skin and eyes from an allo transplant in 2013. I'm 68 years old, and I recently went to a gynecologist, and my Pap smear was negative. She informed me that since I'm over 65, I no longer need annual visits. However, with GVHD and a thinning of my vaginal wall, should I ask to be seen every year?
Probably yes. No, if you have symptoms, for sure, a person should be seen.
Okay. Another woman asked, I'm 8 years after an allo stem cell transplant with 100% matched unrelated donor. My CD4 count has been below 200 ever since until recently when they jumped to over 300. We think that it is the result of taking 3 full COVID vaccines and how they work on the immune system. What are your thoughts on that? Does that sound reasonable?
Well, the immune system slowly recovers over time, and the COVID vaccine wouldn't specifically raise the CD4 count, although it stimulates the immune system to respond in general. But it's good that the CD4 level is going up, and that but it's still one still is never totally back to normal, and always has to be somewhat cautious about infections.
All right. Dr. Pineiro, what is stem cell exhaustion? I'm 8 years post-transplant with 100% matched unrelated donor. Chimerism is 64% donor and 36% mine. How often do you monitor chimerism? Mine hasn't been done in 4 years.
Well, that's a little bit troublesome. Presumably, the stem cells have the capacity to regenerate, and they're supposed to live forever because that's one of the criteria, or by definition, of the stem cells. However, after an allograft, we have to remember that we receive a small amount of stem cells from the donor that could grow over time or regenerate themselves as the stem cells do. But when we have a mixed chimerism like this, it may be that your own cells are trying to recover, and or it may be kind of delayed rejection of the donor cells. So I would be really concerned about it, and I would follow the chimerism in a more frequent basis, because it could be a sign of relapse or late relapse, or just that we're losing the graft.
All right.
How many years? How many years is it post-transplant for this person?
8 years.
8 years. Yeah. So some people argue if your blood counts are stable and you're several years post-transplant, then one doesn't need to worry about chimerism, and people can be mixed or even have autologous recovery, but as long as the leukemia or the underlying disease is not coming back, one doesn't need to do anything about it. So I personally wouldn't fret about the chimerism if everything else is stable at that late date.
Good to know. All right, Dr. Mountjoy, perhaps you can do this one. How do you keep the graft leukemia versus leukemia effect active long term? I underwent 2 allo transplants because I relapsed 2 years after the first one. I'm 2 years out after my second transplant. I have bad prognosis, MDS, AML with complex karyotype and a mutation of TP53. I have GVHD in the eyes, mouth, skin, vagina, and lungs after the second transplant, and was told that I would not qualify for donor leukocyte infusion or stem cell transplant anymore while my GVHD lasts. Are there any treatment options that would be curative for me if I relapse?
Yeah, that's ideally the best thing to optimize graft versus leukemia would be reduction in immune suppression, but in your case, that would not be something that would be prudent to do if you're struggling with, what sounds like pretty extensive GVHD, which is, of course, very challenging. So, the first order of business is try to reel in the GVHD before consideration of immune suppression reduction should be done. We know from the studies through the CIBMTR, which is a big research consortium, that when patients they get transplanted with leukemia have a little bit of graft versus host disease, they may have better graft versus leukemia. But what we don't want to get is lots of graft versus host disease, which is what you're having right now. And optimization of that should be priority. At relapse, outside of doing another stem cell transplant or something on a clinical trial basis, such as a cellular therapy like a CAR T that's in research or something like that, there really are no known curative treatment modalities if there would be a relapse in this setting.
All right. Dr. Pineiro, are monoclonal antibodies preferred to Pfizer's antiviral therapy if an immunocompromised patient with GVHD gets COVID?
I think both are fairly effective. It all depends on the time that they are administered. More and more that we have the availability of these oral medications, that would be fine. But I don't know if there is a direct comparison between the newer oral medications and the monoclonal antibodies.
And so over time, the original monoclonal antibodies no longer are effective against the more recent COVID variants, and but the drugs, the Paxlovid from Pfizer and the other drug from Merck can be considered. The Paxlovid Pfizer drug has got a lot of drug interactions, particularly with tacrolimus. So it's very difficult to give that early post-transplant while you're on immunosuppressive therapy. But if you're off immunosuppressive therapy and don't have those drug interactions, that's a highly effective drug. And I've recently used the Merck drug for which has fewer drug interactions, and you can give it to people early post-transplant for patients who have acquired COVID.
Great. All right, Dr. Champlin, maybe you can handle this one as well. I had a BMT 5 years ago. I'm 79 and I've been through all the childhood disease immunizations. Will I always be considered immunosuppressed, or does that eventually wear off? I'm up to date on all my COVID vaccines as far as I know.
So even in older patients, the immune system will recover. It never totally gets back to 100% normal, but by 1 year post-transplant, if you don't have graft versus host disease, it's like 95% recovered. There is still some delayed reactivity against particularly encapsulated bacterial infections, and so one always has to be cautious about infections and see a doctor if you have a fever. But the immune system gets close to normal about a year post-transplant.
Right, Dr. Mountjoy, you're the lymphoma specialist. I'll ask this one of you. Severe itching and night sweats were symptoms of the angioimmunoblastic T-cell lymphoma I was diagnosed with in 2020. These symptoms stopped shortly after beginning chemotherapy. I had an auto transplant in May 2021. 6 months later, the itching and night sweats began again. My scans are clear. What could be the cause of this?
Yeah, that's a difficult question. Thankfully you don't see signs of relapse, which is the most important thing. Angioimmunoblastic T-cell lymphoma is extraordinarily aggressive, so it's really reassuring that you're over about a year out now. It sounds like you say May of 21 you had transplanted, but over a year out from transplant with no disease relapse, that pertains to a very good prognosis from not having relapse of the disease. It's never going to be 0%, but it is reassuring. You'd want to talk to your physician about other drugs that you could be on that could be causing itching. But I don't think that there's any lingering effects from transplants, from an auto transplant at this point, that could be contributing to that. So I would think about drugs that you could be on, and then your surveillance workup to be sure disease isn't coming back.
All right. Dr. Pineiro, perhaps you can do this one. Chronic GVHD affected the lining of my heart. I had fluid removed and am on prednisone. Could this come back once treatment is finished?
It could. Since we don't know how effective the treatment is going to be, and chronic graft versus host disease may improve and then relapse later on. So, however, we need to taper the immunosuppressants, particularly if it's only steroids in terms of the treatment, and then we'll see what happens. But it needs to be followed carefully, because the other possibility is that, it was not related to graft versus host disease. It may have been a viral pericarditis that the treatment is just about the same, but it has a kind of a different implication.
All right. Dr. Champlin, this person wants to know if you're still on immunosuppressants, is the shingrix vaccine effective? I have GVHD, am on Tacro and Jakofy. All of my vaccines were done on immunosuppressants. Do I need to have them repeated at some point?
At least the rule that we use to give the shingrix vaccine is you need to be off immunosuppression for at least a year and not have any graft versus host disease to get the vaccine, because people with graft versus host disease have even more impairment of their immune system and won't respond to the vaccination.
All right. Dr. Pineiro, this person has very dry eyes. She had an allo transplant, and she's been using prescription and over-the-counter drops for her eyes. At what point do you start recommending plugs for the eyes?
Well, it all depends, and it sounds that it's severe enough that right away the ophthalmologists usually do that. I mean, there are some eye drops, cyclosporin eye drops that specifically designed. It's a kind of a topical immunosuppressant, but they go through that routine. If the regular eye drops or immunosuppressants topically they don't work, then the plugs is the next step. And sometimes they go use a special type of lens called scleral lens, and even to use autologous plasma that presumably lasts longer, or the effects would last longer.
And this is probably a question for all three of you. We've had people who have used autologous serum, autologous plasma, but have had a lot of difficulty getting insurance to pay for it. What has been your experience in getting insurance to pay for autologous serum?
Yeah, that has been a common problem, and what we have done in our center is just we get the blood here, we spin it down so that they don't have to go through that particular charge. And then, but just they have to pay for to get it into a pharmacy and put it into different vials. Yeah, we have had problems trying to insurance to cover for that.
Dr. Champlin, Dr. Mountjoy, any different experience?
Yeah, very similar.
I agree.
Okay.
Yeah. It's always a challenge. It's always dependent on someone's coverage of their insurance, what you can do, what your center can offer. But the key is to have a good, like Dr. Champlin alluded to earlier, a good eye ophthalmologist that can kind of help navigate those things. Eye GVHD doc, I should say.
Okay. Dr. Champlin, I'm going to ask you this question. I think I understand what she's saying. She wants to know whether GVHD of a female genital area is treated the same as oral GVHD, the mucosal lining of the mouth. It's a topic her doctors have been avoiding, and she would like some additional information.
In principle, you can use topical steroids, in the vaginal area in the same way as you use a topical steroid preparation for the mouth. Usually they're different preparations, but the same idea. and then systemic steroids would be the next level of treatment if the topical treatment is ineffective.
All right. Dr. Mountjoy, can the total body irradiation and chemo and graft versus host disease that people get cause metabolic changes that contribute to long-term difficulty gaining back weight that they lost during treatment, as well as respiratory problems and salmonella infection?
Well, it's just something that's kind of been a recurring theme about recovery of immune function after transplant. And of course, especially while you're on GVHD, especially on immune suppression, you're going to be at risk for infection and always have a higher risk for encapsulated bacterial infections, as Dr. Champlin alluded to earlier. I usually tell my patients it's pretty common when they go through a transplant to lose around 15 to 20 pounds just going through. It's quite a procedure, as you know better than anybody. And patients that struggle with chronic graft versus host disease and things like that, it's a very what we call catabolic process where there's a lot of breakdown, and it can be hard to keep weight on and stuff like that. It's very common.
Dr. Pineiro, does COVID vaccine worsen GVHD given that it stimulates the immune system?
It shouldn't. COVID infection could, but again, I don't have enough information as to properly answer that.
Dr. Champlin or Dr. Mountjoy, any opinion on that?
At least I haven't seen any cases where the GVHD appeared to be worsened by the COVID vaccination, and we know COVID is a life-threatening problem for patients with GVHD, so we recommend that they get the COVID vaccine or the EB shield to try to protect them. And we do the vaccination even though we know they aren't going to respond optimally, because if you get some immunity, it would at least modify an infection and hopefully reduce its severity.
Yeah, I have not seen any signaling or any data to say that the COVID vaccine could trigger GVH.
Okay. Dr. Champlin, I'm probably going to mispronounce this drug, but I'm going to give it a try. I've heard that axatilimab has the potential to reverse fibrotic changes to the lungs. Wondering if you have any insight on this.
Well, there's a new drug, the ROCK inhibitor. Forgotten the name of the drug.
Respirox.
Yeah, and it's an antifibrotic agent that's been recently approved for chronic graft versus host disease, and it appears promising for fibrotic conditions.
All right. Dr. Mountjoy, are post-allogeneic patients vulnerable to developing allergies to medicines, plants, food, cleaning products?
Yeah, another interesting question. When we get a donor through the National Donor Registry program, if they have atypical allergies, those need to be reported. Just because if someone has a peanut allergy, for example, that stuff gets reported not just to us, but to the recipient as well, just to be aware that there's a chance that they could pick up that allergy as well. So there are theoretical concerns that you could pick up kind of the allergy profile of what your donor had. So see kind of stuff like that not infrequently. So definitely a possibility.
All right. Dr. Pineiro, my donor was my sister, a 12 out of 12 match with 12,000 cells. I'm 9 months post-allo transplant, and the only GVHD I've had is liver issues. I'm 71. Am I still susceptible to other types of GVHD issues?
I think so. As long as we have alloreactive T cells that are affecting a particular organ, it may occur in other organs. Granted, we still do not understand why some patients develop GVHD in an isolated organ. It may be that it's subclinical in other organs as well, but the primary manifestation is, in this case, in the liver. He may have GVHD in the skin that is not clinically apparent, but there.
All right. Dr. Champlin, May 2019, I had shingles, eruption and pain in October of 2019. I had my in 2019, October 2019, I had my transplant. I still have nerve pain, but no eruptions. Can I now get the non-live shingles vaccine? I did have GVHD of the skin from November of 2019 for a few months.
So how long has the patient been off immunosuppressant?
She does not say. The transplant was in October of 2019, but she doesn't
so
say.
We recommend getting the first of all, we recommend staying on Valtrex treatment for an extended period, and particularly in people who've had shingles in the past. And then if once they're off immunosuppression for 1 year and have resolution of their graft versus host disease, and then off immunosuppression for 1 year, then we would do the shingrix vaccine.
All right. Dr. Mountjoy, I have another non-Hodgkin lymphoma question. I'm on day 144 post-transplant, and I have been HIV positive for 12 years. What kind of questions should I be asking my oncologist as it relates to being both a transplant recipient and an HIV positive patient? By the way, I was diagnosed with non-Hodgkin lymphoma.
And, I know it doesn't say, but if you had an autologous transplant, there's really no major things. If you had an allogeneic transplant or a transplant from somebody else, I don't think that they're outside of all of the common things that we do for anybody else. The other variable to that would be your HIV therapy, and you would just want to be sure that HIV therapy that you're on, they've done a drug-drug interaction to be sure that there's not any interactions with that therapy and any of the other immune suppressant medicines that you can be on. Some of those antiretroviral therapies have a lot of drug interactions and can be challenging to use in combination with some of our immune suppressants. So that would be the kind of the big thing to think about.
All right. Dr. Pineiro, is younger donor age always preferred? Would a relative who is older, for example, like a parent, be preferred over a match or an unrelated younger donor in an adult patient?
That's very interesting, and actually that was addressed in the recent meeting that we have, and apparently that is indeed the case, particularly now that we're using what is called haploidentical stem cell transplants, mismatch transplants from relatives. Apparently younger donors tend to have a better outcome.
All right.
That's true for with haploidentical donors and also with unrelated donors. So the younger donors tend to do better than older donors. And so one question is, if you're like a older adult with brothers and sisters also who are in their 60s or 70s, should we do the matched sibling, or should we try to do a younger unrelated donor or a younger haplo? And at least in our program, we've found that the older matched siblings do pretty well, and we actually recommend using them rather than a unrelated or mismatched transplant, because there's somewhat less graft versus host disease in those patients. That's our own experience.
That's interesting. Can you explain for the audience who may not know what a haploidentical transplant is? So
your HLA system is on chromosome number 6, and so you get half of your tissue type from your mother, half from your father. So you're half matched to your parents, you're half matched to your children, and among brothers and sisters, you have a 1 out of 4 chance of being a complete match, a 50-50 chance of being a half match, or haploidentical is a half match, and a 1 out of 4 chance of being a total mismatch with a brother or sister. So in most families, we can find a haploidentical donor for someone, even if they don't have a perfectly matched brother or sister.
All right, Dr. Pineiro, perhaps you can answer this one. I'm on Jakofy 5 milligrams a day. How immunocompromised am I? Do I need to mask with fully vaccinated friends and family who are no longer wearing masks on a daily basis?
My personal opinion, Jakofy at that dose is not very immunosuppressive. So I think I would be okay to be around friends and family whom have been vaccinated. I don't know if my colleagues feel the same way.
Yeah, so even
I agree.
Even without the Jakofy, I'm still urging patients to be cautious because there's a lot of COVID out there. And even your friends and family may have asymptomatic or minimally symptomatic infections. So I urge them to wear masks and use social distancing. It's a fine line when one can try to move back toward normalcy here, but for the transplant patients, they're at high risk for severe infections if they do get COVID. So I still recommend them being cautious.
All right, Dr. Mountjoy, this woman had a transplant 8 years ago. She's had all her teeth removed prior to transplant. She wonders if she should be concerned about osteonecrosis. She's had skin, joint, and eye GVHD.
Yeah, I mean, if it's reasonably well controlled, I wouldn't be overtly worried about that. Obviously, if you're having any dental procedure done, you'd want to give yourself a break if you're on any bisphosphonate therapy like Fosamax or Zometa or Reclast or any of those drugs. Those are the ones that could increase your risk for osteonecrosis of the jaw. But if your GVHD is kind of reeled in pretty good and you're thinking about getting some implants, I think it's reasonable.
All right. Dr. Champlin, could you talk for a moment about immunoglobulin treatments? Why are they used and who should get them?
All right, so intravenous immune globulin can be given to people who have low levels of IgG immunoglobulin post-transplant. And so for people who have IgG levels less than 400 who have frequent infections, it's recommended then that they receive intravenous immune globulin to prevent infections. And but if your IgG level is over 400 and or if you're not having frequent infections, then IgG or intravenous immune globulin need not be given. So it's a very expensive medication. Insurance companies try to deny it, but it is indicated for people with low levels of IgG and who have frequent infections.
All right. Dr. Pineiro, this person wants to know why they have GVHD. They received a stem cell transplant from a 100% matched donor.
Yes. There are, even though we are HLA match or identical, there are many other things that our immune system are different. I mean, unless you have an identical twin, then GVHD should not occur. But the fact that we are 100% match, there are some other differences that our immune system is capable to see. Minor histocompatibility, antigens, among other things that we don't even know how to measure. So it is not rare to develop graft versus host disease, even if we have a full match.
All right. Dr. Mountjoy, can you explain what iron overload is and if anyone is at risk for iron overload after a transplant?
Yeah, this is one of the most common things that we deal with in the post-transplant setting is iron overload. You know, for kind of to highlight it, one bag of blood contains 17 T-bone steaks worth of iron in it, just to kind of highlight how much iron you get in a single blood transfusion. So generally, when you start getting more than, you start getting into double-digit red blood cell transfusions, you're going to start having what we call secondary iron overload, meaning that we have overloaded your body by giving you blood transfusions. And what we do after transplant is we phlebotomize that iron off, meaning that it's kind of like donating blood, where you donate your blood, but we just pitch it and throw it away to get that iron level in your bloodstream down. And then we can do other things like chelation therapy if you're not eligible for getting your blood phlebotomized. And that's generally if your blood counts haven't fully recovered yet.
All right. Thank you. Dr. Champlin, this person is 57 years old and 5 years out and 20 years postmenopausal. She wants to know if she should get the HPV vaccine, or is that only for younger women?
It's recommended for younger women. So once you get to be her age, she's been exposed already to the virus, and the vaccine no longer is recommended.
All right. This person wants to know if there are any data on using steroids versus Jakofy and Rezurock for GVHD and the relapse rates for high-risk leukemias. Anyone want to take that?
Well, that's a kind of a tricky, just to kind of make it thoughtful. So, we use prednisone or steroids as our kind of our frontline treatment for whether it's acute or chronic GVHD. If patients are intolerant of steroids or the GVHD does not respond to steroids, then we go to a drug like Jakofy. Rezurock is only for chronic GVHD and really should be, as we alluded to earlier, kind of for those fibrotic changes that we see with chronic GVHD. Each one of those therapies are immune suppressive, and if suppressed, there's the risk that when you suppress the immune system that you could suppress your graft versus leukemia, and there could be increased risks for relapse. But that's hard to fully quantify because it's kind of based on, how aggressive the disease was at transplant and other multiple variables that kind of come into play with that.
All right. Dr. Champlin.
So chronic graft versus host disease is associated with the graft versus leukemia effect, and so we try to use immunosuppressive treatment to control the symptoms, and then taper it as best we can to minimize the immunosuppressive effects, and to use the lowest dose that controls the symptoms of the disease, of the chronic GVHD.
All right. Dr. Champlin, I'll give this one to you as well. This woman had AML secondary to treatment for breast cancer. She had a stem cell transplant in July of 2021. And recently, she had elevated bilirubin of 4.2. An ultrasound of the liver and gallbladder was perfectly normal twice. She's had Gilbert Syndrome for at least 30 years and is wondering, could the chemo be making the liver value worse? All other values in CBC are normal for me.
Right, so Gilbert Syndrome is when the indirect bilirubin is elevated. And so we need to know, in her case, is it direct or indirect bilirubin that's elevated? If it's the indirect, then it's usually not a medical problem. But if it's the direct bilirubin, then that does indicate liver injury.
Okay. The gentleman who asked about the study drug, axatilimab, said that it is indeed axatilimab. It's not Rezurock. It's an SNDX drug and an agave study. He's wondering if it has the potential of reversing fibrosis. Does anybody have any familiarity with this drug?
That's in early phase studies. That I think is our hope that drug will kind of move through the phases and show in patients that it can reverse it. But I don't know that we're ready for prime time yet on that drug to say, yes, this is going to reverse it. I think that's the hope, and we just need the tincture of time to see how that shakes out.
Thank you. Dr. Pineiro, how do late complications differ for someone who had a related transplant versus someone who had a cord blood transplant?
Well, I mean, they could be different, and it's probably mainly related to the development of graft versus host disease, either acute, but most importantly, chronic. Cord blood transplants are characterized by less graft versus host disease, but by the nature of the stem cell, I don't see that there is any difference. It has to be related to the development and severity of graft versus host disease.
Okay.
Yeah, in our experience, in adult patients who've gotten cord blood transplants, often there's a very prolonged immune suppressive period after the transplant before the immune system recovers, and patients often have frequent virus infections. And so this is a bigger problem, again, in adult patients getting cord blood transplants than a matched related donor transplant. Children seem to do better with cord blood transplants, probably because they get a better, cell dose per kilogram body weight because they're smaller, and the results in children are better than in adults with cord blood.
All right. Dr. Mountjoy, perhaps you can try this one. Do I understand this correctly? I have osteopenia post-2018 allo transplant. I've been off prednisone and tacrolimus for 3 years. I take calcium and vitamin D, and I'm in the middle of getting a tooth implant. Do I need to stop alendronate, and for how long, due to the risk of jaw degeneration?
Yeah, depending on how big of a procedure that you're gonna undergo, and if I personally recommend at least a couple of months off the bisphosphonate to prevent osteonecrosis of the jaw. That's it's hard to fully quantify, and I don't know if the other docs on the call have a other opinion on that, but I personally, just because of that risk when manipulating the jaw and drilling in there and cutting stuff out and putting implants in, I'd at least a couple of months off the bisphosphonate before that's going to be done.
Okay. Anyone else?
Yeah, it is unclear how long we have to wait. Biphosphonate have a long half-life there in the bone, so but it depends on their priorities. They need to be done, but we usually recommend 2, 3, 4 months of holding that medication.
All right. Dr. Mountjoy, my husband is due for an autologous stem cell transplant in July. How safe is the procedure during COVID? How many stem cell transplant patients contract COVID after transplant and die? And how is it best to protect these patients?
Well, it was really scary there for a while when this pandemic first hit us, and we had these just brutal strains circulating. For our autologous stem cell transplant patients, we have a handful of requirements. One, nobody who is unvaccinated for COVID is allowed onto the transplant floor. Number two, we offer all of our patients undergoing autologous stem cell transplant to get Evusheld, either right before the transplant or during their hospital stay for the transplant in an effort to top off their antibody levels. We have in recent months with all of our things like Evusheld and Paxlovid and the other tools in our arsenal to reduce the risk of severe infection have done very well recently compared to how we were doing a couple of years ago. So it's, to tell you how risky it would be on an individualized basis based on kind of what your social situation is and how many people live in the home and stuff. But the ideal scenario is that all caretakers would be vaccinated, ideally get him some Evusheld injections, which are those monoclonal antibodies that we've been talking about. And if, God forbid, he gets in contact with COVID and is symptomatic, get immediately on Paxlovid, and hopefully he does well.
Okay. Next question, Dr. Champlin. Are second cancers influenced by the original cancer you had treated with BMT? In other words, are second cancers more common on survivors who have had a specific cancer type?
Okay, so with autologous stem cell transplants, there's a big concern with secondary myelodysplastic syndrome and therapy-related acute leukemias, and that occurs in the patient's own hematopoietic cells as a result of the chemotherapy. Now, with allogeneic transplants, the patient's own blood cells are eliminated by the high-dose chemotherapy and replaced by healthy cells from the donor that haven't seen any chemotherapy. So they generally don't get this therapy-related myelodysplastic syndrome, but there's a chance of getting a second solid tumor, and so the rate of secondary cancers is somewhat elevated going forward, and it's of multiple types, so not any specific organ.
Okay. Dr. Pineiro, this person has the sensation of a tight band around their chest, and they're wondering if this could be an indication of graft versus host disease.
Yeah, sometimes we do have some restrictive pattern in terms of the lungs. And it's related, if they have had GVHD in the lungs become stiff per se, and the only way to know that is by doing a pulmonary function test. In addition, if they have had skin GVHD, the subcutaneous tissues may become fibrotic and really tight, and that may be the feeling or what they're experiencing.
Okay. Dr. Champlin, is there any new information on why the leg cramps and diarrhea side effects of Revlimid last for years? I haven't taken Revlimid for 8 years and am still plagued by these side effects. I did take it for 6 years as maintenance after a transplant in 2006.
I can't explain why Revlimid causes diarrhea or why the patient would still have it, but there's many causes of diarrhea, of course, and so you'd want to make sure that they've been fully evaluated for other diseases associated with diarrhea.
Anyone else?
Yeah, I don't know if we fully understand the mechanism why. I would say that the best treatment for that diarrhea, assuming that it's not something else as Dr. Champlin alluded to, it would be to trial cholestyramine or also known as Questran. I think that is the most effective treatment for Revlimid-induced diarrhea. And generally, people that go on that do have a substantial improvement in their symptoms. They use that powder and use about a half a packet of that in the morning and see if that helps their symptoms, and then you can kind of slowly add it on.
All right. Dr. Pineiro, this person wants to know if it's always the case that patients need transfusions after a transplant.
Not always. We have several patients that undergo autologous stem cell transplant and they don't need transfusions, and there are some centers that for Jehovah's Witnesses, they are able to proceed with the transplant without transfusions. But for the most part, yes, the vast majority of the patients undergoing transplant, both autologous and allogeneic, will require transfusions.
All right. Dr. Champlin, is 1 gram of CellCept twice a day, that is 2 grams daily, to control GVHD considered to be low, moderate, or a high dose of immunosuppression?
I think that's the standard dose of CellCept. So we actually give it 3 times a day initially as prophylaxis, and but if you're using it for treatment of graft versus host disease, you taper you use the full dose, and then if the GVH responds, then to taper the dose back.
All right. Dr. Mountjoy, this individual is 4 years post-transplant for non-Hodgkin lymphoma, and his energy levels are still low. Is this normal, and what can he do about it?
Yeah, so, and again, hard to tease out from that if you had an autologous or an allogeneic transplant, a transplant from your own stem cells or transplant for somebody else. But what we do generally in our center is it's very common to have a lot of hormonal disturbances after transplant. So around about 3 months after transplant, we get basic labs, including thyroid function, testosterone, and or estrogen levels, all those sorts of things to see, did we, push a woman into, menopause early based on what we did, or, did we deplete the testosterone levels in a guy, and should we be putting them on replacements and optimizing their thyroid and all of those things, because it is very common for your endocrine system, or your system that governs kind of your energy and metabolism levels, to kind of get stunned and banged up during transplant. So those levels, I think, are important to check and are an important part of survivorship after transplant.
All right. Thank you. Dr. Pineiro, is 78 too old for an autologous transplant?
Never say never, but yeah, sometimes we write some criteria, and I remember that, we didn't see, when I was in training, we didn't see anyone beyond the age of 50 to do a transplant, and then as we grow older, then our criteria change too. So 78, it all depends on how fit and how it's their performance status, and there's really no good way to know. Sometimes some people ask them to exercise or to do a more thorough cardiopulmonary assessment before transplant. And it all depends on risk versus benefit. I mean, do we really need to proceed with the transplant? Are there other treatment options now that we're having other treatment modalities that can be applied, like for example, CAR-T?
All right. Well, with that, it looks like our time is drawing to a close. I'd like to thank you, Dr. Champlin, Dr. Mountjoy, and Dr. Pineiro. And on behalf of BMT and our partners, I'd like to thank you, the audience, for your great questions, and our speakers for their wonderful responses to your questions. If you have any other questions, please don't hesitate to contact us at bmtinfonet.org or email us at help@bmtinfonet.org. Have a great rest of the symposium and a great rest of the day.